Assalamualaikum warahmatullahi wabarakatuh and good morning. My name is Henny. I am a resident specialist program in clinical pathology, Hasanuddin University. The first time I would like to say thank you very much to my supervisor, Dr. Nursin Abdul Kadir, Master of Health Specialist Clinical Pathology, and Dr. Tenri Esa, Master of Science Specialist Clinical Pathology, who has guided in making this case. I feel happy to join in this SciTech Central Conference and participate in this virtual seminar activity. Well, I will present my case with the title is The Light, a diagnosis of opportunistic infection from Mycobacterium tuberculosis in patient with human immunodeficiency virus or HIV leads to fatal consequence. For the background, he knows HIV infection is a risk factor for TB. Vice versa, TB infection accelerates the progressivity of HIV. WHO recommends the collaboration of HIV-TB to accelerate the diagnosis and treatment of TB and HIV while reducing the burden of society and government due to this disease. TB and HIV infection is a serious heart threat and could lead to fatal consequences if not treated properly. In this presentation, I will explain several things include the first, introduction, the second is anamnesis, the third is physical examination, the fourth laboratory, and the fifth discussion. Introduction. HIV is a cytopathic virus from family Retroviruidea, subfamily Lentivirinae, and genus Lentivirus. HIV can infect immune system cells including CD4 or T helper cell, macrophages, and dendritic cell. HIV consists of HIV-1 and HIV-2, but the HIV-1 is group cause the most severity. HIV has become the worst the world community because besides the absence of the vaccine for prevention, it also has relatively long window period and asymptomatic phase in the journey of the disease. It is a collection of symptoms caused by decreased immunity due to infection with the HIV. As the body immunity deteriorates, AIDS begin to show symptoms due to opportunistic infection, which are caused by microorganisms that don't usually causing serious illness. This is the table common opportunistic infection and malignancy in patients with untreated AIDS. Opportunistic infection can be caused a protozoa as a toxoplasmosis, isopropyl infection, cryptosporidiosis, the fungal pneumocystis cerovesi pneumoniae, cryptococcosis candidiasis, histoplasmosis, coccidioidomycosis. From the bacteria Mycobacterium tuberculosis, Mycobacterium avium intracellular complex infection, the virus, herpes simplex, CMV, varicella zoster, IgG virus, opportunistic malignancy, Kaposi sarcoma, and lymphoma. This is a viral characteristic. We know that the HIV virus is round with a diameter of about 100 until 120 nanometer and numerous nodes producing from the surface of the virus indicates the GP 120 antigen or surface, but the GP41 or transmembrane antigen crosses the viral envelope and is closely related to surface. And then this is the matrix or P17, which is located in the viral envelope and maintain the viral structure and the formation of new virus replication. And the virus nucleus is composed of the capsid P24 antigen, and the two single-chain viral RNA and virus protein includes the nucleocapsid. I will explain the viral entry virus replication cycle HIV. The main target of HIV are T lymphocyte and macrophage, which have the CD4 surface antigen. The HIV virus attached to CD4 via the GP120 antigen. In addition to the CD4 antigen, use a core receptor that is specific to HIV. The virus can enter the host cell with the CXCR4 on T lymphocyte or CCR5 on macrophage. And then HIV GP120 binds to T cell CD4, and conformational change in GP120 promotes binding to chemokine receptor, and conformational change in GP41 expose fusion peptide which insert into T cell membrane and fusion of viral and cell membrane. This is the viral post-entry. The HIV virus enters the cell, then the enzyme in the nucleoprotein complex become active and start the virus reproduction cycle. Viral nucleoprotein nucleus break viral RNA is reverse transcript into double-stranded DNA or dsDNA by viral reverse transcriptase enzyme, and then the viral DNA enters the nucleus. Viral integrase enzyme also enter the nucleus and catalyze the integration of viral DNA into the genome of the host cell, which is called a provirus. Provirus can be inactive for months of year with little or no production of new virus, so HIV infection can be latent. The viral gene expression begins when infected host cell become active. Viral DNA in the host cell nucleus is transcribed into genomic RNA and messenger RNA, which are transported to the cytoplasm. And furthermore, mRNA translation occurs with the production of viral precursor protein and viral particle. The compilation of viral particle begins by encapsulating the transcript of the RNA from the provirus genome in nucleoprotein. And this nucleoprotein complex then detached from the plasma membrane with the host glycoprotein of the viral envelope. HIV transmission can occur through three ways, include sexual contact, contact with blood or body fluids, and from mother to baby. The first, most HIV infection is transmitted through sexual contact, but both vaginal and anal contact. As many 85% of cases of HIV infection occur in heterosexual contact. And the second route of transmission is exposure to infected blood or body blood, which mostly occur as a result of sharing needle by drug users. The third route of transmission is perinatal transmission, in which an infected mother pays in on her fetus or baby. Transmission can occur during pregnancy, during delivery, or during breastfeeding. This is the laboratory marker of HIV. Various HIV marker for diagnostic purpose can be found in the patient blood at different times with the HIV RNA, P24 antigen, and HIV antibody. HIV RNA level are the first marker that can be detected using a nucleic acid amplification test or NAT, qualitative and quantitative, in 10 days after infection. And the viral RNA levels increase rapidly and remain elevated for several weeks before level drop to a detectable baseline. The P24 antigen is the following marker, can be detected in 4 until 10 days after the initial detection of HIV RNA. the production of P24 antigen is transient and will decrease to undetectable level as antibody to this protein appear due to the formation of an immune complex that intervenes in the detection of P24 antigen. And HIV antibody, the next marker is antibody HIV. We can detect it in 4 until 12 weeks after infection, and in nearly all patients within 6 months. HIV specific IgM antibody can be detected 3 until 5 days after the appearance of P24 antigen, and 10 until 13 days after viral RNA is detected. And IgG antibody levels rise rapidly about a week later and reach a plateau for a few months and remain high for years. This is a therapeutic monitoring test. The first is CD4 lymphocyte test. This is the table, the HIV stage in based on CD4 T cell parameter based on age. And the second is viral load or HIV RNA with the quantitative test. Tuberculosis. Tuberculosis is still global public health problem and is an infectious disease that is still a problem in the world of health today. Tuberculosis became one of the top 10 deaths worldwide in 2018 and the leading cause of infectious disease. Tuberculosis is a disease caused by Mycobacterium tuberculosis. This is the characteristic of Mycobacterium tuberculosis. Mycobacterium tuberculosis is an obligate aerobic, facultative intracellular parasite, and humans are the main reservoir. Mycobacterium tuberculosis is non-spore-forming, non-motile, facultative, curved intracellular bacille with the 2 until 4 micrometer in size and 0.3 until 0.6 micrometer in width. The cell wall contains microglycolipids rich in acid, long chain, and phospholipoglycans or mycosites which protect the mycobacteria. TB is infectious disease caused by Mycobacterium tuberculosis, opportunistic disease that are often found in AIDS, and the main cause of death in AIDS around 40 until 50%. This is a laboratory diagnosis for TB. We can use bacteriological examination. We can use microscope, gene expert, and culture. From the microscope, we can use light microscope and the fluorescence microscope. Light microscope, we can use Zell-Nelson and Kinyon-Gebet. And the fluorescence microscope, we can use Oraminstein. For the culture, we can use H-based media with Lowenstein-Jensen and Ogawa. Agar-based media, we use Meiderbrook, and automatic liquid media, we can use Bactec. Case report. Patient data, the name Mr. N.R., age 22 years old, with the status not married, and from Hospital Labong Baji. 23. Anamnesis, a 22 years old male patient with the initial NR was referred from a regional hospital with the diagnosis of HIV and was admitted to Labong Baji Hospital, Makassar on 7th September 2020. He had a main complaint of fever and month before admission, accompanied by coughing, difficult breathing, and diarrhea. He experienced 70 kilograms weight loss with the last 3 months. There was no history of TB with a known history of contact with TB patient. The patient received IRV treatment for the last 3 months, the patient had a rapid clinical deterioration and died 2 days after diagnosis with TB. Physical examination: blood pressure 110 per 80 mmHg, with the pulse 84 per minute, with respiratory rate 20 H per minute, temperature 38 degrees Celsius, and we find the anemic conjunctiva and large lymph nodes are absent. Vesicular breath sound, pure regular 1 and 2 heart sound, cardiac noise was found, and peristaltic was normal, the liver wasn't palpable, and the spleen was not palpable. With the laboratory routine blood test, we get the result anemia. Immunology test with the parameter anti-HIV with the result reactive with 3 reagent, and microbiology test with the test smear microscopic with the result negative, and the expert MTB result MTB detected low with the rifampicin resistance not detected. In chemical examination, we found increased transaminase enzyme and hypoalbuminemia. The thorax, we find active pulmonary TB. Discussion: there were 1.14 million new cases of HIV and TB co-infection, and 400,000 that were attributed to co-infection in 2015. CDC recommends that all patients with active or latent TB to be screened for HIV because HIV is a well-known activator of latent TB. The risk of TB increases by 25-fold in early HIV infection and by more than 20-fold in advanced HIV disease. The risk of TB remains increased by approximately 4-fold in patients infected with HIV treated with ART. Opportunistic infection of TB in HIV patients increased along with the degree of severity of immunosuppression due to decreased CD4 T lymphocyte. As the main mediator of the body's immune defense, HIV patients had or high risk of TB contraction or activation of dormant MTB from previous latent TB. The common clinical appearance of TB in HIV complicates the early diagnosis of TB in HIV patients. The late diagnosis of TB will worsen the immunity of HIV patients, thus accelerating death in patients with HIV-TB co-infection. Examination recommendation: the first, check the number of CD T lymphocytes. The CD T lymphocyte count is an indicator of the immune function of HIV-infected patient, and monitor the effectiveness of ARV therapy, and a short-term predictor of the risk of opportunistic infection. The second, viral load test. Viral load examination plays a role in monitoring patient response to ARV therapy and predicting disease progression. And the third is you must TB screening in HIV patient. Thank you.